9. We're going to start the craniofacial portion of today's presentations. I'd like to welcome Wendy Daubel Thompson, who is our patient representative to this panel, Dr. Ed Fitzgibbon, who is our ophthalmological expert, Janice Lee from NIH, as well as Dr. Fitzgibbon from NIH on craniofacial, and Dr. Andrea Burke from the University of Washington, Seattle. And I will get out of the way and let them continue.
Okay. Thank you so much. Okay, so good morning, everyone. Thank you so much for having me. Am I projecting loudly enough for everyone to hear? Okay. So this morning, Dr. Lee and I will be talking about the craniofacial and dental implications of fibrous dysplasia. And if anyone has any questions, please feel free to interrupt at any point. Currently, I'm an oral maxillofacial surgeon working at the University of Washington in Seattle. And I completed my clinical research fellowship with Drs. Collins and Boyce at the NIH. And today, I'm diagnosed. How and when do the lesions show up? Where are most of these lesions located in the craniofacial skeleton? Will I get more lesions over time? And then, very importantly, what sorts of functional problems can occur? And we'll talk a little bit more about that later in the talk. And then lastly, of course, how do you treat craniofacial fibrous dysplasia? So I always like to start with a little bit of anatomy because I'll be referring to a lot of these structures. And the reason for this is that the craniofacial bones are some of the most complex in the skeleton. For instance, laboratories are also helpful. And then sometimes the biopsy is helpful because the diagnosis can't be made just on the basis of history and physical or radiograph. And that's really the only indication is if we're suspecting something else. So here are two patients from the NIH cohort with craniofacial fibrous dysplasia. And as you can see, the degree of their facial asymmetry varies considerably. The patient who's on our left actually has McCune-Albright syndrome, and the patient who's on the right has monostotic disease of the right maxilla. But as you can see, that they both have some forms of asymmetry. The eyes are not level in the patient with McCune-Albright syndrome. She has a little bit of what we call proptosis, or her eye is being pushed out. The angles of the corners of the mouth are not level. The nose is expanded at the base, and other such findings. And so what are we really looking at when we're looking at the craniofacial exam? So when Dr. Lee and I are going to see a patient, these are the things that are like registering to us. So it's actually quite a lot of things that we're looking at all at once. And this is just an example to show you of all of the different points and things that we're looking at. And then as far as symmetry, if you look at the pictures on the right side, we will often divide the face into fifths or thirds to get a sense of symmetry. And that helps us if we're going to be treating and doing a surgery. And I always like to put this slide in because I think I get a lot of questions, especially from parents, about radiation risks. And since, as a oral surgeon, we tend to send people for a lot of imaging studies, I think it's important to point out that, especially in this day and age, and these numbers might even be too high because they're from last year, every day CT scans are getting less and less radiation dosage risk. So your typical daily background radiation, I'm just using these units for the sake of simplicity, millisieverts, you get about 3 millisieverts per year. So an airplane flight, which I just took, is 0.03 millisieverts. And then as you go on, you can see how much a chest X-ray is, an intraoral or one of those tiny dental X-rays, bite wing X-rays, the Panorex, which is that dental X-ray that goes around your head, all the way to an ICAT or a cone beam CT that focuses directly on your jaws, and then a full head CT, which is only about 2 to 4 millisieverts. So when you look at your daily background versus how much a head CT is, you can see it's actually pretty minimal. And then a bone scan, of course, actually has quite a lot more radiation, but presumably you're only getting one of those at once every few years. Okay, so here are just some plain X-rays showing an instance of fibrous dysplasia on the left, and another patient with no involvement on the right. And as you can see, the plain films aren't really the best way. You can sort of get a sense that there's something different and there's something fuzzy about the bones, but it's not really the best method for looking at bones in the skull. Here are some dental X-rays. These are panoramic or Panorex X-rays, which show the difference. The patient on the top has fibrous dysplasia, and you can appreciate that the bone looks a little bit more dense in the sinus area, and it's opacified. And then finally, as we talked about, the CT scan as the gold standard. And so what I've put up in the right-hand corner is that we'll often look at CT in 3 dimensions. So there are 3 different planes. One is axial, as if you've been cut across your midsection, and then there's sagittal, as if you've been sort of cut in half, and then coronal or facial, which is looking at somebody dead on. And so here you can see on the bottom, this is the axial or the transverse plane, and we can play around with the different image windows so that we're preferentially looking at the bone. And what you can see here on the left side is that typical ground glass appearance of the fibrous dysplasia with the arrows that we're often discussing. And then finally, bone scan. Here you can see this person has a bone scan which shows monoastatic disease of that zygomaticomaxillary complex region. This is a technetium 99 bone scan, and the way that it works is that you basically receive an injection, and those areas that have increased metabolism in the body will take up the tracer. Okay, so craniofacial fibrous dysplasia on CT, as you've already seen a little bit about, there's obliteration of normal architecture and the landmarks, and the cortex, which is that thin eggshell you can think about of the bone, actually remains intact, but it becomes expanded. And what you can see on the right side is that fibrous dysplasia actually doesn't always appear the same way. On the top panel, you can see more of a ground glass appearance. The bottom, or the middle, sorry, has more of a mixed, and then the bottom has more of a lytic appearance. And what we know is that the appearance on CT scan can actually change over time, and this has been reported. So it's not always uniform, and this actually does not make the diagnosis so easy. So when do fibrous dysplasia lesions typically present? Well, we know that craniofacial fibrous dysplasia lesions are the earliest to occur, but can remain silent until the deformity or growth starts to occur. And what we know by a study done by Hart et al. Back in 2007, they showed that about 90% of the lesions were detectable prior to the age of 15. And so, and actually 90% of all craniofacial fibrous dysplasia lesions were detectable on bone scan by the age of about 3. So no new craniofacial fibrous dysplasia lesions were reported beyond the age of 10. And this sort of goes along with, you know, a lot of what we've been saying, that you do not acquire more of these lesions over time. You're sort of born with what you have, and it should be detectable on something like a bone scan. So how do these lesions progress? Well, the top shows a patient at the age of 5 and the same patient at the age of 15. And on the right side is just an area of reference, so you can see the area that we're actually looking at in the skull from that top-down view. And what you can see in the lower right is a skull that's uninvolved, just for comparison. And so on the left, again, you can see this sort of ground glass, you know, more whitish-looking appearance on the CT scan in the frontal region. And then here is the same. A different patient, again, age 5 and age 15, showing you the uninvolved in the right corner, and we're again looking at that sinus area, and you can see that over time it's gone from more ground glass appearance to more of a mixed appearance in that maxilla over there. And I don't know if I can point to it over here. And then here is a patient showing the lower jaw. This is the mandible. And again, you can appreciate the difference from age 5 to age 15, the change in the radiographic appearance. as the lesion not only is expanding, but it's also becoming a little bit more lytic or lighter on the CT scan. So, will more of these lesions develop? No, the answer is more new lesions are not likely to develop. However, as we've just talked about, lesions can expand and may change over time. And radiographically, we've just seen that. But what these are suggesting is that the activity of the bone-forming cells might be changing as a person ages. And what we do know is that some of these most dramatic changes can actually occur within the second decade, which is sort of why I think historically people have said around puberty you'll get, increased growth. And I don't think that that is really fully understood, but we do understand that when people are going through hormonal changes, it will affect how their bones are growing. And then in others, fibrous dysplasia lesions can become associated with other rapidly growing lesions, such as aneurysmal bone cysts or other conditions. And what we do know is that it's actually extremely rare to transform a typical fibrous dysplasia lesion, which as we all know is benign, into a malignant tumor. And that has been shown to be less than 1% in prevalence. What we also know is that growth hormone excess can exacerbate the growth of the bone lesions. So at this point, I'm going to second decade, which is sort of why I think historically people have said around puberty you'll get, increased growth. And I don't think that that is really fully understood, but we do understand that when people are going through hormonal changes, it will affect how their bones are growing. And then in others, fibrous dysplasia lesions can become associated with other rapidly growing lesions, such as aneurysmal bone cysts or other conditions. And what we do know is that it's actually extremely rare to transform a typical fibrous dysplasia lesion, which as we all know is benign, into a malignant tumor. And that has been shown to be less than 1% in prevalence. What we also know is that growth hormone excess can exacerbate the growth of the bone lesions. So at this point, I'm going to turn it over to Dr. Lee, and we'll go over a little bit of the functional problems.
Oh, yeah, it's not a mic.
You can't hear you.
All right, thanks very much, and thanks for the great introduction. Andrea, as you saw, did a fantastic job giving the foundation of the anatomy that we're dealing with, but more importantly, and on a day-to-day basis, the questions that patients have for us is really, what are the functional problems? And it's really the information that you and this organization have provided to us. So really, the questions that have come up over and over again include vision loss or vision disturbance, hearing loss, dental problems, and numbness. We know that in fibrous dysplasia and vision loss, we know that in polyostotic FD, the most common area is actually the anterior cranial base. And that we know that more often than not, fibrous dysplasia seems to be wrapped around the optic nerve or involving the optic canal. What's been unfortunate, though, is that there have been sporadic reports throughout literature suggesting that vision loss happens suddenly and acutely. And this has been established mainly because of some of the older literature. And you can see from this study in 1968, the most common reported neurologic symptom was supposedly vision loss. However, let me point out a couple of things to you about this study. This study was back in 1968. It was based on plain films. So you saw what plain films looked like. And when Andrea showed you the normal plain film and the one that had fibrous dysplasia, you can see all you see in fibrous dysplasia is a fuzziness of bone. So all the architecture of normal bone and normal anatomy is obliterated. But you have no idea really how bad the situation is, because in plain films, which is what this study is based on, it's all superimposed with other structures. So to get a really good idea of what's happening to the optic nerve really is impossible with those types of images. We have actually new images now that help us quantify and look more carefully at the optic nerve, which is really important because that will dispel this idea that vision loss is the most common neurologic symptom. So based on that study and several earlier studies, the assumption was made that when you find fibrous dysplasia around the optic nerve, that you will inevitably have constriction of that nerve, and you will inevitably have blindness. And this is just an example of what we've been seeing. Now, what I'm here to say to you, though, is that this concept that you will have inevitable blindness is not true. Absolutely not true. And the reason we can say that is we have longitudinal data. As you can see in this patient on the left, a 5-year-old female who has fibrous dysplasia throughout her skull. And if you look carefully at her CT, which is a 3-dimensional rendering of a CT, you can see that the optic canal is actually involved. You see 10 years later, the same bones are involved. And as Andrea has mentioned, you can see that there are changes in the bone. But what has happened is that the optic canal has decreased in size. That we know because we now have 3-dimensional information. We know that the optic canal has decreased in size. However, in this particular patient, her vision has remained normal. And this was a study, probably one of our landmark studies, where we were able to demonstrate in 2002 that fibrous dysplasia, yes, will often involve the cranial base. Yes, it will be often found around the optic nerve, but very few people will actually go on to become blind. What we have noticed, though, that there are visual changes, and Dr. Fitzgibbon will go over that in just a little bit. There are vision changes, but whether it's the FD or the fibrous dysplasia constricting or causing stretching is really unclear. In our study, what we found was there was, in fact, a statistically significant narrowing of the optic canal. However, that did not translate to folks having blindness or having abnormal eye exams. In fact, the vast majority of our patients actually had a normal eye exam. What we then proposed, and what we still feel today, is that prophylactic optic nerve decompression, which means before anybody's blind, you prophylactically go in, scoop out the fibrous dysplasia as best as you can to prevent inevitable blindness. So we've determined that, in fact, that's not helpful, because as you can imagine, trying to get to the optic canal requires a really big surgery. And if it's not done well, and if it's not done right, and it's not done frequently, the experience of the surgeon can play a huge role. And as you can imagine, the surgery itself has its own complications. And in fact, when we looked at the number of folks who had surgery, almost a third had what we believe is complications related to the surgery itself. So in fact, the question still remains, is this beneficial? And from our standpoint, we don't think it is. We think in this particular case, waiting and watching is actually the best treatment. FD is not a progressive condition, and it is not a condition that will result in inevitable blindness. I also want to talk very briefly about hearing loss. This is some of the work that Dr. Jeff Kim has done. And what we've noticed that there may be abnormal ear or hearing tests, and that tends to be the most common audiological finding in polyostotic FD, and that's because the ear canal is also involved in fibrous dysplasia. When hearing loss does occur, it's typically mild, meaning it would be very hard to find the hearing loss except with a test. There are two types of hearing loss. It's called sensory neural, in which the nerve is actually affected, the hearing nerve is actually affected, and this is less common, versus conductive hearing loss, meaning any part of the hearing apparatus is involved with fibrous dysplasia, and there may be some constriction or there may be some changes that cause this mild hearing loss. What's actually rare and uncommon is a cholesteatoma, and that's when there's abnormal skin or keratin tissue growth behind the eardrum, and this is actually quite rare. But more commonly is a narrowing of the ear canal, and that's because the ear canal is encased in fibrous dysplasia. This is just a schema of the actual anatomy that we typically assess, both clinically and with Xrays or CTs. And as I mentioned earlier, the ear canal is typically where we'll see the common finding of narrowing. We also found that 20% of the NIH cohort did have some mild hearing loss, and it appeared to be related directly to the inner ear. And this is just an example of a normal CT where you could see the normal anatomy with all the inner ear components. But this is a CT in which you see the entire inner ear and all the components of hearing have been encased in fibrous dysplasia, and that's that whitish bone that appears thickened. Normally you see the black spots, those are the mastoid air cells, and that's normal. But with fibrous dysplasia, all that is obliterated, and then the structures in the inner ear are now encased in bone, or the otic capsule. Another common finding in those with fibrous dysplasia of the craniofacial region includes congestion. And that's actually because fibrous dysplasia appears to be involved in the nasal cavity or the turbinates, which are structures inside the nose. As you know, the nose is really important for humidifying the air, for filtering, and to maintain moisture throughout the airway. Additionally, the sinuses may be involved, and as you saw from the previous CT, the sinuses can be completely obliterated with what looks like white fibrous dysplastic bone. The actual function of the sinuses are questionable or are controversial, and we do know that when there are areas, in particular the maxillary sinus, when those are involved, we can have patients complaining of congestion or sinus infection or frequent sinus infections. We do know that the nasal cavity and the sinuses are often involved in FD, and as you saw earlier, and here we go, as you saw here and earlier, the maxillary sinus, which is a normal maxillary sinus, aerated and black, but a sinus that's involved with fibrous dysplasia, that can cause some congestion, and the complaints that patients will indicate that they feel like there's stuffiness in their nose. The far right CT demonstrates a sinus, or the ethmoid sinus air cells, which are now completely blocked by white bone, and that's fibrous dysplasia. What we did find, though, despite the fact that congestion may be common, we did find that actual sinus infections were not common, meaning patients were not constantly or frequently requiring antibiotics. And so this is a finding that Dr. Jeff Kim noted earlier. So when we think about fibrous dysplasia and the management of fibrous dysplasia, we think about a multidisciplinary team. And oftentimes, for the craniofacial region, we think about dental specialists, and they include pediatric dentists, because oftentimes the children will be the one first to be identified with the lesion in the craniofacial area. Orthodontists are often involved, and they're the ones that will provide kids with braces. Oral and maxillofacial surgeons like Dr. Burke and myself, prosthodontists, and these are specialists who help replace missing teeth. Periodontists are those who are specialists in gum disease or periodontal disease, and endodontists, they are the ones that will do root canals if a tooth needs to be salvaged. I forgot there were all these cartoons. Because fibrous dysplasia, or McCune-Albright syndrome in particular, has so many more complex and more serious conditions associated, the dental aspects of this condition are often overlooked. But we do know that this may be a common problem and is a real issue in quality of life. We know that there are variable presentations, and as all our previous speakers have noted, not one patient is alike. So we have to be prepared to address their complaint. Oftentimes the patients will receive quite a bit of dental therapy, and the question has been whether these dental treatments will cause exacerbation in the fibrous dysplasia. What we also know from a study by Sundayak and Toya is that there is a slightly higher rate of cavities or caries in this group, and whether it's the access to care, the frequency and hygiene, or really a component of the impact of this disease, that remains unclear. We also know that there is a very rare finding in fibrous dysplasia of the craniofacial region, and that's medication-induced osteonecrosis of the jaw. This is actually uncommon, but we have seen it. And this is where the bone is exposed in certain the bone is exposed in specifically bones of the oral cavity, like the upper jaw or the lower jaw. These are just some of the dental anomalies that a patient with fibrous dysplasia may express or be identified to have, and that's attrition, which is the wearing of the teeth. They may have retained teeth, extra teeth that don't fall out normally. Toroodontism is when the roots and the root pulp, or the pulp of the tooth is much too large. Enamel hypoplasia, or enamel findings that are abnormal. Displacement of the teeth, but typically the displacement is mild. Oligodontia, which is missing teeth, and then rotation of the teeth. And this is just an example of some of these findings that I had mentioned. Toroidontism is the far right, where you see an enlarged pulp chamber. And this is just the enamel wear and unusual components of the enamel. And you can see that when fibrous dysplasia is in the bone, there may be some missing teeth, and that's oligodontia. What is interesting, what I should point out, though, is not all of these anomalies are found just in fibrous dysplasia bone. Some patients will have these anomalies with or without fibrous dysplasia being present. What we also find is that if a tooth is found to be in an unusual place, especially when the fibrous dysplasia is in the maxilla and you've got a tooth bud that's in the area, you may see what looks like a floating tooth. And these teeth may have to be removed if they don't provide a function. Sorry. This is just an example down below. I wish I could show you. But where the teeth look like they're floating, and that's because the fibrous dysplasia has impacted the tooth buds. In really severe cases, once the teeth have to be removed, a child may need a prosthesis or a crown or a bridge or a small partial denture. But again, exceedingly uncommon. When we think about orthodontic therapy, the majority of patients will complain that their teeth have shifted some. And that's because of the push of the fibrous dysplastic bone on teeth. At times, the occlusion may be significant, but we typically find that in patients the patients who have growth hormone excess or other endocrinopathies. And typically, this is much worse when the endocrinopathy is not managed or under control. When we think about crowding or dental malocclusion, orthodontic treatment is the way to go, because we do know that orthodontic treatment does not appear to exacerbate the bone. It does not seem to make things worse. And patients actually respond quite well to orthodontic therapy. But what we may recommend is that the braces and the retainers have to be kept in place for a little longer, because there is the tendency for what's called relapse, meaning you get the teeth in nice position, the fibrous dysplasia bone may continue to enlarge, and then there may be some movement in the teeth. So our recommendation would be that you retain longer than typical. But we do suggest that patients proceed with orthodontic therapy. The question has come up, should braces be delayed until skeletal maturity? And we feel that that is not actually necessary, because tooth movement can be obtained even in fibrous dysplasia bone. When there's an extreme malocclusion, like you see in this photo up on the top left, it may require jaw surgery on top of the braces. And that's when you'll see a specialist like Dr. Burke and myself, where both braces and jaw surgery may be necessary. And this is where we may say that you should wait until there's a complete skeletal maturation, so that there isn't movement in the jawbone and there isn't continued expansion of the fibrous dysplasia. What we have noticed in the few cases that have been done with patients with fibrous dysplasia is that healing does occur, normal healing does occur, but again, we may recommend that the immobilization is kept a little longer than normal. That brings us to the point of dental implants, and these are metal posts that are placed in bone when you have a missing tooth. We also note that there are very few cases that describe dental implants in FD, but we do know that it can be done. We do recommend that you monitor for normal bone healing, which is typical, but there may be a much slower level of integration. For dental implants, the implants are placed in bone, we allow a period of integration, and then we start to load the implant. Because fibrous dysplasia bone tends to be softer, we do recommend that you allow the integration period to be a little longer than normal. And this is just an example. There were cases reported in which a person with McCune-Albright syndrome, a 32-year-old female, underwent this treatment, and after 5 years it was clear that she had a successful outcome. As in most cases, though, we do recommend, for example, that dental implants are placed when there is skeletal maturity. And this is not just for fibrous dysplasia patients, but it's for patients who are still growing. We do implants in patients with cleft lip and palate. And just because there's continued growth in all children and all young people, the best way to have implants placed is when there is complete skeletal maturity. So I want to just very briefly talk about osteonecrosis of the jaw. This was formerly considered related to just bisphosphonate therapy, but in fact we do know that, for example, denosumab may cause the same condition. And this is when there's necrosis or death to the bone because of a loss of blood supply. And this is typically seen when the bone is exposed to bisphosphonate therapy or any medication that may impact blood supply to the bone when this has been in place for much longer than a few months, or the medication's been in place for longer than a few months. Some of the medications that cause osteonecrosis of the jaw include bisphosphonates, denosumab, anti-angiogenic drugs, or tyrosine kinase inhibitors. What's really unusual is why does it affect jaw bones primarily? This is not a condition that we see in orthopedic bone or long bones, and the question still remains unanswered. We do know that from a study here at the NIH that about 5% of those on any one of these drugs may have bisphosphonate-induced osteonecrosis of the jaw. So how is craniofacial FD treated? As I mentioned earlier, it would be really important to have a multidisciplinary team because you need multiple specialists looking at the craniofacial bones, and this is just a list of the experts that would ideally come together to manage any condition of the craniofacial region. We do, however, recommend that treatment is based on the aggressiveness of the lesion and the extent of the lesion. As you already heard, treatment is still on, treatment therapies are still being discovered, but the most important thing is to listen to the patient and to follow the biological behavior of the lesion. And if it's a quiescent lesion, meaning it's stable and there's no evidence of growth, if it's a non-aggressive lesion versus an aggressive lesion. And in most cases, when there's an aggressive behavior, that's when we would recommend treatment. How am I doing for time, by the way?
I think you're fine.
Okay. One of the most critical findings from the work at the NIH is that monitoring is actually a good thing. And typically monitoring with close observation and close follow-up, that may be the best, the best treatment option for most patients. And that includes monitoring for any sensory changes, including the vision, and using imaging when necessary. And again, that would depend on what we find in terms of our clinical assessments. We often take photos of the face, and there is new technology now. It's called 3D photography, where we can follow growth and changes in the facial region. Unfortunately, as you can imagine, this is an identifying feature, and taking photos can be somewhat problematic, but we do use all efforts to maintain the identity of the patient and to maintain confidentiality. But this really does help us determine whether there have been changes in the way the face appears over time. And medical management is something I'll leave for the bone experts and the bone pain experts. Some of the indications for surgery. I know not every patient undergoes a biopsy, but we will recommend a biopsy if it's questionable, because there are several features of fibrous dysplasia that are what's called pathognomonic, meaning when we see it on an X-ray, there are some features that are so classic and so typical for fibrous dysplasia that may be the only need to help with the diagnosis. And as you can imagine, if the craniofacial region is involved and the skull base is the most common area, and if that appears to be the site of involvement, we wouldn't recommend a biopsy of the skull base, simply because it's a very complex, a very difficult area to reach, and the risk of doing a biopsy is high. So if it's a reachable area, we may recommend a biopsy, but if it's not, based on X-rays, we may make the diagnosis. Some of the surgical options for the craniofacial area include contouring. And while folks may suggest that this is a cosmetic issue, as you saw, it's not just cosmesis. It's really an issue of asymmetry of the face and normal function. We typically recommend that this is done, though, when growth is complete. We may also recommend resection and reconstruction, and that's if a lesion can be removed completely. But as you saw, some of the lesions are so extensive that we wouldn't recommend resection because the defect itself would be much worse than the condition alone. So the patient may be referred for contouring. And then the other surgery that we typically perform is orthognathic surgery, and that's jaw surgery where we would move the jaws around to help get the best fit for teeth. And again, this may be both a cosmetic procedure, but more often than not, it's a functional procedure in which we can get the teeth and the jawbone to now be in balance and to be in harmony. One thing that we do have to note, though, is that even if the surgery is done after growth is complete, there's always the chance for regrowth. We do recognize that patients who have surgery in the craniofacial region have to be monitored for quite some time, just to be sure that if there is any signs of regrowth, that we address it immediately. And as I mentioned earlier, we don't do this for cosmetic purposes. Typically it's a functional issue, but also it's a psychosocial concern because many times the degree of asymmetry is pretty extreme, and we have to take into consideration the patient's psychosocial needs as well and quality of life. This was a study done by Alison Boyce here who looked at the literature and looked at the database at the NIH and found that there in fact were a number of procedures that had been done on the patients that were seen at the NIH. And what she noted is that the vast majority of these patients had procedures done for facial asymmetry, as you can see in the pie graph down below. And those are the indications for surgery. And again, facial asymmetry being the most common, followed by malocclusion or jaw deformity, and then nasal airway obstruction, and then obstruction to the otic canal. What we noticed that there was less regrowth when aneurysmal bone cysts or bone biopsies were performed. And that may be a little skewed because aneurysmal bone cysts, when scooped, and their normal treatment is when cleared and scooped, that's typically definitive treatment. So FD associated with an aneurysmal bone cyst, when treated properly, there did not appear to be regrowth potential, nor with bone biopsies. And this is information we have to get out to our surgical community because people do worry that doing a bone biopsy may stir up the FD and cause problems. But in fact, from the database here, we've seen that that does not actually occur. When we do something as aggressive as a bone resection or reconstruction, there is less regrowth. But as you can imagine, when we do a resection, that's a lot of bone. And typically that means we have to reconstruct. And sometimes the reconstruction is an extensive surgery, like a free fibular flap, where you take a piece of bone from some other part of the body to reconstruct the defect. So these morbidities are something that you would have to discuss with your surgeon. Was that a hand? Or? Yes. Can we take questions? Is that okay?
Typically, we're going to wait till the end.
Okay.
Can you
Okay.
hold that?
Sure. Sure. What we did note that in this cohort is that when patients have growth hormone excess, and in particular growth hormone excess that is not well managed or well controlled, there appeared to be a much greater risk for regrowth. And this is where early diagnosis and early management of the growth hormone excess is critical. Based on those findings, we felt that it was really important to encourage a multidisciplinary approach to craniofacial fibrous dysplasia care. And that typically means both surgeons and medical providers, both for management of the endocrinopathies and also the pain. So I want to thank everybody for taking the time to be here. But the information that both Mike Collins and Mara showed earlier in terms of the progression of this organization gave me pause. And I realized that there were several members of the original team that have since passed away. And while that's a big hit to our community, I do want to point out that there have been a number of people that have joined the team and taken over our positions. For example, Andrea Burke, who has really taken on a big role in craniofacial fibrous dysplasia, and Alison Boyce, who has also taken on a big role in pediatric endocrinopathies. And so while we had a significant loss, people like Mara Ramanucci continue to push forward for research and for greater advancement. And I think what I realized as well is when I first gave a talk, it was when this group was part of the MAGIC Foundation. And it's such an evolution to see that the Fibrous Dysplasia Foundation has now become its own entity, is now taking on an international flavor, and now considers research a critical component to the culture. So I commend you for the amount of advancement and evolution that has occurred in a very short time. Thank you.
So I'm Dr. Fitzgibbon, Ed Fitzgibbon, at NIH. I'm a neuro-ophthalmologist. Neuro-ophthalmology is a subset of ophthalmology, and it's a specialty where we're interested in things that affect vision either in the eye or the brain. And one of the parts of the brain is the eye, because it's really an extension of the brain. And specifically, the optic nerve is the thing that we're going to talk about. And it's optic nerve compression, how to monitor, how to act. Both Dr. Burke and Dr. Lee set me up for this, and pretty much you've heard the bottom line. Vision loss in fibrous dysplasia is only going to happen if you have craniofacial involvement, if you have bones in your skull involved. And most of those people, of course, will be McCune-Albright syndrome. And then the question is why, and the why is because of the bone, of course. And I have just some anatomy pictures here again. These are schematically drawn. Here's a side view of the eye. There's one of the muscles that's been cut off. You can see that the optic nerve is going to the back part of the bony skull, bony orbit, and it goes through an opening which happens to be in a specific bone, the sphenoid bone. And that bone turns out to be often involved in fibrous dysplasia, McCune-Albright syndrome. So same picture looking from above, and again, it's the back part where you see the yellow. I'm not sure if does this not work at all? Probably doesn't, but no, it doesn't. Anyway, so the back part where you can see that the optic nerve is coming off the eye. Here is another picture. In this particular one, the eye is sort of transparent, and you're looking just front on at the orbit. You know, the orbit looks like a little cave. And the back part, the optic nerve goes through the bone, and it's going back, and it'll go to a part of the anatomy called the chiasm. It's where the pituitary is. This is a more realistic, but it's colored in, but it's the same idea. The one that says optic foramen, sort of where that circle is, that's the normal size, and that is a part of the sphenoid bone. And that's what the optic nerve has to get through. Here's just some skull pictures. These are CTs. They're axial, so it's a cut through this way. And the ones on the bottom are from somebody who had a normal scan. The ones on the top are somebody who had severe involvement with the skull. And what the part you're looking at is, on the left, there's a line drawn. That line, they can actually reformat it so that it's the canal. And again, if you look where the yellow arrow is, you can see that that's really narrow in comparison to the bottom, which is really hard to see anyway. But again, on the far right, where there's a yellow arrow again, that canal is surrounded by abnormal bone. And the worry, as Janice pointed out, was that you have all this abnormal bone, isn't it going to cause a problem? You know, should we do something prophylactically to compress it? So the problems with decompressing it, as she knows, is that first the bone is really thick. You have to get through. When you're drilling, you're causing heat. That can be transmitted to the nerve. And it's kind of hard to know when to stop. You have white bone and you have a white nerve. So here's just a blow-up of the same thing. You can see on the left is a normal, and on the right is just bony encasement. Just another picture. So, doesn't the optic nerve get compressed in an adverse way that makes it so you don't see? Really, the answer is, in most cases, no. And again, as Dr. Lee said, we don't recommend people prophylactically, just to prevent a future problem, doing any kind of surgery to open up the canal. The other part is that the bone regrows anyway. But it is a good idea to follow up with your eye doctor, and really regular exams, probably annually, but if you're having problems, obviously more often is a good idea. So I just wanted to go through, so you see an eye doctor, what do we do? Why are we doing it? The standard eye exam is really looking, that I'm doing, is really trying to concentrate on optic nerve function, really, because that's what we're talking about. There's bony encasement, and we want to make sure your optic nerve is working okay. So the simplest thing is just to check your vision. I'll show you what that looks like. A better test is a side vision test. Color vision, contrast, and we look actually at the head of the optic nerve. When we look inside the eye, we can see where the optic nerve is, and I'll show you a picture of that. And more recently, we've got a new toy to play with, optical coherence tomography. It sounds like a mouthful. But it gives us a very interesting kind of way of looking at the retina and the optic nerve, and I'll show you that too. So this is the one you look at this and you read it, and you come up with a number. So the number is 20/40. What does that mean? You can the person is the top number, and the normal is the bottom number. So if you're seeing 20/40, you're not seeing quite normal. 20/20 is usually considered at 20 feet what other person can see at 20 feet. We actually use other kinds of things, and we tend to use decimals. So 20/40 would be 0.5. And often we even use the log of that. But anyway, you understand what this is. Humphrey visual field is one way of checking your side vision. It's a machine where your head is put into a thing. You're asked to look straight ahead at a little point. Lights come on in the periphery, and it's a threshold test. So if you see it, you push a button. Okay, next time it shows it to you when it comes back to that point at a lesser level. If you don't respond then, it'll show it higher. And it comes down to just where you can barely see it. And what you get from this test is the result on the right. If you look at those circles at the top, there's sort of a gray area, and then there's some dark spots. The dark spots are the normal blind spots, and it's on the left side in the left eye and the right in the right eye. What it represents is where the optic nerve is, because as the optic nerve exits the eye, there aren't any photoreceptors there, so you end up getting a blind spot. Well, how come you can't see it? You actually can. If you just use one eye and you put your finger around 15 degrees out, it disappears. Your brain fills this in. It's interesting when people say somebody's blind, they think that they see black. They don't see anything. It's not black or anything. It's just not there. Ishihara color plates, you're probably all familiar with this. It's interesting that maybe 5 to 8% of males have red-green color blindness. That's one of these tests. And contrast, here's the letters are fading out, and we have normative data for how far down this chart you should be able to see, and it's a way of quantifying it. So looking at the optic nerve, it looks really pale from this side. It's a little hard to tell. The reason I showed this particular picture was the one on my far right, your far right too. On the side of it, it looked a little whiter than on this one, but it's not showing up well in this, so it's hard to tell. But the point is that we look at the color, but nowadays we have another way of doing it that gives us possibly more quantifiable information. And I just wanted to talk a little bit about what is the optic nerve? What are we doing here? This picture here is a side view of the retina, and the retina is interesting because it's transparent, light comes in through the eye, goes through the retina, and hits the bottom part where these long cone-like things, they're actually called cones, they're photoreceptors. When they take the light energy, turn it into electrical energy, it percolates up through the retina, which is going towards the inner part of the eye. And on the top there, you can see all these lines coming out. Those are axons. They're coming from the top part of the retina, the ganglion cells. And those axons stream into the optic nerve. And they actually are what makes the optic nerve. The optic nerve is composed of about 1 million axons from all these parts of the retina in this kind of configuration. So the optic nerve is really what's transmitting the signal from the retina. And we can actually look at it with a new kind of machine. It's called an optical coherence tomography. What you're doing, you're shining light in, and in a fancy way, it's kind of like ultrasound. You can figure out the timing for the light to get back in different reflective layers. It's more than I can actually understand, but they give me a nice picture. So a side view of the retina, this part here is the retinal pigment epithelium, and these are the different layers. This top layer here, that's the nerve fiber layer. That's what those axons are. This divot here is actually where it's called your fovea. It's what you actually look at when you're reading something. The reason we can move our eyes around is because we have foveas. It's actually, you're trying to, you know yourself, if you want to look at something, you look at it. You have to move your eyes or your head to actually look at it. But what you're trying to do is actually put the fovea, whatever you're trying to see, it has the highest concentrations of these cones. This is more information than you wanted, but what we get out of that OCT machine is this kind of a plot. And it's a little hard to see. It's small here. But what it's giving is a side view of the retina, and it has a way of quantifying that innermost layer, that retinal nerve fiber layer, essentially the axons that are composing the optic nerve. And what we do is we do it right around the optic nerve and measure it all the way around. And then there's normative data, that green part here. The red part is 2 standard deviations different, and almost always it's less. It's hardly ever more. And this would be a normal one. And the other thing you can look at the top, it's just a heat map, and it shows you the same kind of, what's the density of the nerves. And the first time you look at it, you have no idea what you're looking at, but you get used to it, and this one is a normal one. Abnormal, the lines that are going through the be down in the red. So that gives us an idea, is there loss of nerve fibers? Why would that happen? Well, in this particular case, because there's a compression of the optic nerve in some sense, and obviously bone is the obvious candidate if you have McCune-Albright syndrome. So despite, having this ugly, the vast majority of people don't have eye problems from the bony encasement. So you should avoid prophylactic surgery. Now, Janice mentioned that there were some patients in our study that did have problems. Some of the patients had prior surgery, so it's hard to know if the prior surgery caused the problem or did they have it before that. And there wasn't always clear records. Another possibility is that, and most of the people that did have that also had endocrinopathy, specifically growth hormone excess. And they were mostly adults also. So my suspicion is growth hormone excess for a long time, and I think this is what Dr. Boyce and Collins would say also, causes more bony problems, specifically possibly causing more problems in this area also. So growth hormone excess is a bad actor in this particular case, and really it's important to try and keep it at a normal level to the extent that it is possible, specifically, as you're growing. So what other kinds of things can go wrong? Well, aneurysmal bone cysts are something that can cause a problem because it's something that's changing very quickly. I think that one of the reasons why you can get along with all this bony encasement is it's very gradual, and possibly, it's hard to know. I mean, this is sort of hand-waving at this point. But But other kinds of things obviously can compress the nerve. If that happens, it's going to be a sudden change, and obviously you should see somebody very soon, emergently, rather than putting it off. Usually, the sooner we notice something, the better that we can try and save it. We don't have any good way of bringing back vision, unfortunately, but we do have ways to try and keep it from getting worse, or if it's done very acutely, sometimes we can actually improve things. A couple of other things, just these are other kinds of eye things that come up once in a while. If you have a lot of bony involvement of the orbit, your whole eye can be pushed forward. So that can make it harder to close your eyes. You can end up with getting dry eyes. Another thing that can happen is that the lower lid and the upper lid have little canals in them, puncta, that drain into the nose that take the from the eye. And the fluid in the eye there's a baseline, and then there's when you have tears. So if your eyes are dry, you might have tears. But if you're just the baseline kind of thing, it tends to collect in these areas here and then get drained by these puncta. But if your whole lid is pushed forward, that lacrimal lake, that little area of tears, doesn't function correctly, and you don't get them, and you can get epiphora, which is tearing down your cheek. But that can come from irritative things too, so you have to sort of make sure it's not an irritation. One thing you can easily try is if you are having any of these kinds of problems, artificial tears are over the counter, they're easy to put in, and oftentimes it can make your eye feel better. There's other kinds of things that Dr. Lee also mentioned was dystopia. The two eyes are at separate levels. Truthfully, I haven't seen the patients that I've seen, very many people who've had double vision. It's certainly a consideration, but I think that for the most part, even when people have had very widely separated eyes or very asymmetric eyes, they still don't have double vision, and I think it's partly because it's so gradual that you can accommodate it, that people get used to it and do the right thing and keep both eyes focused on the same areas. So just what's the bottom line? Really, I think annual exams are more than reasonable, that it's a good idea just to make sure that everything's going on, that everything's going well and you're not having any problems. And sometimes you might have something gradual just show up on a visual field. And certainly there are other common things that you can find also, such as glaucoma. But really the usual course is to have no significant involvement as far as vision from craniofacial involvement. But with the caveat that growth hormone has to really be considered, and if abnormal, probably more frequently followed. So that's mine. Thank you.
Thank you.
I'm Wendy. I was born July 2nd, 1963. At 2 weeks old, a cafe au lait mark started forming in the corner of my mouth, down my neck, my chest, my arm, my shoulders. I even have a little spot in the middle of my back. When I was 10 years old, my dad noticed a lump above my left eye. At that point, they diagnosed me with von Recklinghausen's disease, or today known as neurofibromatosis. They did surgery and through biopsy discovered that I had fibrous dysplasia. When I was 13, I was diagnosed with scoliosis. The Shriners then ran a full set of Xrays and found that I had fibrous dysplasia throughout my body. When I was 19, I started getting terrible migraines. and my ribs started fracturing or microfracturing. In my early 20s, I woke up one morning with a very bad migraine, and my right eye laid to the center. I couldn't pull it any further forward than straight on. I was admitted to the hospital with a suspected aneurysm. After about a week, they brought in a neurosurgeon that had just moved to Spokane, and he was from Southern California. He told me he saw a case of fibrous dysplasia in Southern California. At this point, I knew there was me and one other person in the world. He then decided that due to possible swelling around the sixth nerve and fibrous dysplasia involvement, that the sixth nerve was being damaged. He did surgery, decompressed the area around there, and told me I'd wear an eye patch the rest of my life. I said no. So every day I stood in front of the mirror, I stared at myself, and I turned my head still staring. I don't know if it helped the nerve or not, but 3 months later, I took the eye patch off for good. In my 30s, my doctors decided to run full panel blood work, and at that point discovered I had growth hormone excess. I was then put on sandostatin to control that, and I was diagnosed with McCune-Albright syndrome. At the same time, my gums started expanding also, and eating was becoming difficult, and closing my lips together was becoming very difficult. My ribs were also becoming very painful, but at that point we dealt with my gums, and I had 2 surgeries to reconstruct so that I could close my lips together again. And the first time I was able to eat anything that I had been craving, I went straight for an apple. I had not been able to eat an apple for a long time. So then I decided to complain to doctors about my ribs again. And even though in the past I'd been told there was nothing to do about the rib pain, they ran chest Xrays and found that I had a pleural effusion on the right side. They tapped the fluid off, got 1.3 liters of fluid, and 3 days later tapped another liter. The common thought that the fluid was forming was because my ribs are so deformed from fracturing. So I was in my 30s in the 90s, and the internet came around. My friend had the internet. So I went to her house and I searched fibrous dysplasia till I couldn't find anything further. The 2 things that came up was a support group online and the NIH. The support group was called Fibrous Dysplasia Support Online. We had one common email address. Everybody wrote into it. It was distributed to all of us, and we asked questions, we supported each other, and we became a network. I joined when there was about 100 people. So now there was me, somebody in California, and 100 people in the world with fibrous dysplasia. As soon as I was able, I asked my doctor to contact the NIH and find out about the noted research that I had found online. He contacted Dr. Collins, and they had said if I was interested, they would contact me when the study started, and I would have a chance to join. I joined as patient number 11 in 2008. The NIH also suggested that I try bisphosphonates for my rib fractures. It helped the pain by almost 90%. I was almost pain-free in my rib cage. Well, prior to my first trip to the NIH, I contacted everybody in our support group and asked if there was anybody in the area that we could get together and meet. I was anxious to meet somebody else. We met at Union Station, and there was quite a large group of people there, and we had lunch. I was seated across the table from a couple that were local, and we sat and shared experiences and different surgeries that we had had. I mentioned to them that when I got discharged from the NIH, I would have a couple days to be a tourist, and what did they suggest? Charlie and Andrea suggested I go to their house and they would show me around the town. Going on 20 years, we're still the best of friends. So, my left eye was starting to become pushed out, and I had fibrous dysplasia growing in my forehead, behind the eye, and a golf ball-sized tumor in my cheek area. When I would blink, my eyelids would turn inside out, so it was becoming very painful and not very functional. We traveled to Seattle. We found a doctor there that performed a 12-hour surgery to reconstruct my eye socket and my cheek and my forehead. In 2006, I started having black spells in my right eye. Sometimes they would last maybe a couple minutes, sometimes they would last 15 to 20 minutes. And depending on how long they would last is kind of what determined the severity of the black. We consulted with Dr. Collins, and he suggested cluster headaches. My doctors in Seattle suggested the optic nerve was deviated and possibly lending to the black spells. I went ahead and did the optic nerve, the optic canal decompression surgery, and that was the second time it had been done on that eye. A week later, the black spells returned, and they got me in to see a neuro-ophthalmologist in Seattle, and he took one look at my records and said I was having ocular migraines, or cluster headaches that Dr. Collins had suggested. I wish I wouldn't have had that surgery. I regret that surgery a lot. So this whole time I'd been on the bisphosphonates for approximately 10 years. I'd been on very high doses and frequent doses. I started with pamidronate and switched to zoledronate, Zometa. And about 7 or 8 years ago, I had a dentist decide that my fillings needed to be replaced. He botched one of the fillings in a molar on top, and it got infected in the root and blew out the root of my tooth. The tooth had to be pulled, and we knew what possible consequences were from doing this, but we had no choice. I did end up with osteonecrosis of the jaw, and I've had 7 surgeries to debride the area of necrotic bone. I've had personal struggles. Sorry. I wondered all my life who would want to be with me. I felt fibrous dysplasia was my baggage, and I wasn't sure anybody else could carry that along with me. However, 10 years ago, I had a couple dates with a man who I felt was very different. So on about our 4th or 5th date, we took off on the Harley and we ended up in a park. I thought I had him cornered here, and he wouldn't be able to leave alone. He'd have to leave with me. And I decided to tell him about fibrous dysplasia and the surgeries and treatments that I had had. And although it had been very obvious that I have something wrong with me, he had never asked, and we'd never discussed it. So I told him all about it, and He sat there very quietly, staring at me, not saying a word. Finally, I said, "Have I scared you?" And his comment was, "You'll have to try harder than that to scare me off." 6 years later, he proposed. And again, I never thought anybody'd even want to be married to me. And now this guy's proposing to me, and I didn't sleep for 3 nights. Now we've been married for over 3 years, and he's the best thing that's happened to me. As far as my work goes, I'm a graphic designer. I've been at my job for over 14 years. I learned early in my adult life that I must be honest with my employer and let them know that I could be out for surgeries or treatments or days of just not feeling well. My employer has been so supportive and allows me the time I need and never has said one thing about it. So besides all this with fibrous dysplasia and the surgeries and the complications and everything, I feel fibrous dysplasia has brought many opportunities in my life. I've gotten to meet so many people with fibrous dysplasia, and we are all alike except different. I've also gotten to be a patient at the NIH in the natural history study, off and on for 20 years now, and I love thinking that I'm a part of helping them get answers. So in 2003, one of my trips to the NIH, we got together and had a luncheon at Charlie and Andrea's house. Most of the people left, and there was just a handful of us left, so we piled in their hot tub with our glasses of wine. And we all sat around and knew that we wanted to start a nonprofit foundation. We all had a common interest, and we wanted to be able to help others with it and to hopefully someday fund research. We did form a board of trustees, and we became a legal nonprofit foundation. The next year, my dad passed away, and my family asked in lieu of flowers that donations be made to the Fibrous Dysplasia Foundation. The foundation was able to open its first bank account with $1,700 in donations from my family and friends. I think I've been fortunate in that I've gotten to lead a fairly normal life. I have bumps in the road, which are my surgeries or my treatments or the days I don't feel very good. But for the most part, I lead a fairly normal life. I also told myself early on, no one can help me if I don't help myself, and I am my best advocate when it comes to medical care. Without the support from my friends and family, I would not be the person I am today. Thank you. Took the wrong thing off.
Can I ask the members of the panel to return to the front so we can ask questions? All right, I'm going to ask these pretty fast. Hopefully we can respond to it. This would be for Dr. Burke or Dr. Lee. How important is it to have a pediatric dentist with FD experience? If it is important, is there a database or such of such dentists?
You know, I would have to say, as much as we want to have a multidisciplinary team, if a pediatric dentist is available and comfortable managing the dental issues, by and large, the dental issues that a person with FD has is a typical dental problems that somebody without FD has. And our research shows that you really don't have to treat these folks differently. More importantly is probably being sure that the pediatric dentist knows if there are signs that there may be things beyond FD, that they refer to their physician or their pediatrician to test for other things beyond the bone problems. Do you want to say anything else?
I think the only thing to add is that, because this is such a rare disease, there really is no one with expertise per se. I think that many dentists get very nervous if they see something that they're unfamiliar with, and will tend to get worried about treatment. So I think finding somebody who feels comfortable, maybe not having all the answers, but at least being able to say, you know what, I'll go ask somebody who does, or I'll go consult some sources, where I can get more information. I think that's the most important thing. And to be able to have that frank discussion with your provider so that you can all be on the same page.
I'm going to ask you to hold on to that. Should a dentist or oral surgeon be notified if you've had bisphosphonates, and at what point after treatment do symptoms, if any, occur?
So the answer is absolutely, especially in this day and age with what we know about medication-related osteonecrosis. And as Dr. Lee was pointing out, it's not just the bisphosphonates anymore. We know that it's other drugs such as denosumab and other drugs, tyrosine kinase inhibitors, all these anti-angiogenic drugs, even in things like interferon, which are prescribed off-label for many different uses. So I think it's very important to be honest about the medications that you're taking, and also to know what the duration is, whether it's been taken orally or whether you've received it IV, because the things that we do know about osteonecrosis is that you have a higher risk of getting it with IV drugs as opposed to oral drugs, and that the longer you've been on it, the longer your bones have had an opportunity to absorb and hold on to this medicine, so the effects could potentially be worse. That being said, there's a lot of research going on in this area, and there's still a lot that we don't know about it. So I think, being an active participant obviously is very helpful. But, that being said, if you do need to have a dental extraction, or if you do need to have some sort of procedure that's a little bit more invasive, and we're talking mostly surgery, not just, cavities and fillings and root canals, it's important to have that risk-benefit discussion with your provider so that you can be aware of what you're getting into.
I think this is probably Dr. Fitzgibbon.
Okay.
Is it possible that FD could cause unconsciousness in case the skull base is affected? And what about seizures?
I actually don't know. There's not enough information, really. The unconsciousness, I'm not sure how long, whatever. It sounds, it could be from just syncope, meaning that your blood pressure dropped. I mean, that'd be a common cause. But, I would say unlikely, but I can't rule it out. What was the second half?
What about seizures?
So, yeah, again, I don't think it's common. I think that if you have seizures, it's probably just you have two diseases. But, a lot of seizures are caused by areas of the brain that have had some kind of problem. Essentially, the brain itself is abnormal in that area. Could that be caused by the bone? It seems really unlikely. Possibly from prior surgery, that could cause scar tissue, and that can set you up as a seizure. But again, these are rare instances. So
this question goes back to probably our first panel. What makes FD grow aggressively after surgery?
I don't think anybody really knows, but what we're finding is that there is a period, and it's typically the second decade, when somebody's in already a very high metabolic period, and to do surgery while they're growing, hormones are raging, pubertal spurts are happening. All these things seem to exacerbate when the FD lesions will grow. It also seems to be a period where the bone changes occur. So we had talked about the ground glass appearance eventually progressing to a more lytic or appearance that it looks like Swiss cheese. We see from our research that the biggest time for this change occurs in the second decade, meaning age 11 through 20. It happens that's also when the kids are growing. That's where the greatest hormonal changes are occurring. So it all seems to happen most commonly in this phase, but we don't really know why.
Okay, we've had a couple of questions from people in their 20s regarding expansion into adulthood, and how common is that?
Again, I think everyone's different, but we do see that the biggest period of growth is in the second decade, but then it's not to say that the lesions can't continue to grow after that. More often than not, it slows down after you hit 20. Seems to slow down, and again, that could be because skeletal growth has stopped as well. But it's not to say it can't happen, but we don't see that big growth period past 20. We would recommend, though, that clinicians follow patients because there can be slower growth after 20, and if a patient at that point says, I really want to have something done with the asymmetry or this lesion in the jaw is really affecting my ability to chew or function, that's about the time that we would recommend doing the contouring or the debulking procedures.
Okay, and I've gotten a couple questions regarding how often should follow-up happen. We say you should follow up, but what does it really mean?
Follow up for what?
In general.
In general, say in your 20s.
I mean, you should follow up with your primary care physician for a history and physical once a year. I think that sort of is baseline. It sort of depends on what specialties you're seeing. I think we talked about, as far as eye exams, it would be great to see somebody at least once a year. And then if you have the need to see a neuro-ophthalmologist. As far as craniofacial goes, it really depends on how active your lesions are growing, I would say. And, in the period where growth is happening very rapidly, I wouldn't say it's completely unreasonable, to be seen every 1 to 2 years and getting imaging maybe on every 2-year basis, just to make sure that nothing is being missed. But there really are no guidelines, so it really is on an individual basis, I think, to make that assessment.
And you may want to make a comment.
I think she said it.
Yeah, I think one of the big points here, though, is especially when you see somebody for the first time, that they see you regularly just so that they get a basis and a baseline and an understanding of how your disease is behaving. Most of the clinicians are going to treat you based on disease behavior. We don't have a magic or a crystal ball to say what's going to happen. So I think most important is really having every patient develop a relationship with somebody, and typically in the first few years really try to understand how is the disease progressing. If it's stable and it's quiet, chances are whatever area is affected, you'll probably lengthen your follow-up period with that provider. But if it's growing and it's active, they'll certainly want to see you more regularly. But it really probably most importantly means you have to develop a relationship. Your physician needs to understand your baseline, and based on that, they'll have you come back to understand how your disease is developing.
How common is tinnitus, and can anything be done about it?
Our ENT specialist, our ENT expert is not here.
Do you know?
But tinnitus, it's pretty rare.
We
looked at it recently.
A lot of people do have tinnitus as you get older.
So Dr. Boyce is saying that it's less than 10% in those who have tinnitus, and I suspect it's going to be related to those who have fibrous dysplasia around the otic capsule or in the area of the ear bones. Tinnitus can happen to the average person as well. So if you don't have fibrous dysplasia in the area of the ear bones, chances are your tinnitus is not related to FD, but uncommon.
Okay. The more common questions. How common is double vision, peripheral loss, aggressive floaters, and macular degeneration?
With or without FD.
So can I have the card? So how common is double vision? Actually, it's pretty uncommon. As I said, most of the changes happen after such a slow period for the most part that people just adjust to it. So they don't have common, double vision's rare. It can certainly happen from other causes. I mean, you can always have more than one disease or more than one problem. And not everything's attributable to, bone disease. Peripheral loss, peripheral loss happens if you have optic neuropathy, which is what we're talking about with optic nerve involvement. But again, as I said, that's uncommon also in this disease. Aggressive floaters, it's not related to McCune-Albright or to craniofacial problems. You just have, if you have aggressive floaters, it's likely you're very nearsighted. Macular degeneration has no connection. It's very common if you're old enough. I think it's over 25% of people over 80. And seizures and TIA-like symptoms, again, I don't know, and it really, as far as I know, hasn't been reported at all. So I think that, again, it's likely two things rather than just one.
I sometimes have issues with dental anesthesia. Sometimes it works, sometimes it doesn't. Could this be FD related? Dr. Burke is shaking her head no.
It's more likely the technique.
I would have to agree. I mean, Ed's bringing up a very good point. When you've got fibrous dysplasia in areas where there are nerves, the nerves are being pushed around a bit, and the anatomy is not always normal. When we're trained to give local anesthesia, we're assuming that the anatomy is normal, and we know where the nerve is. And every now and then, with fibrous dysplasia, especially when there's expansion in the bone, we have no idea where that nerve enters the jawbone or comes out of the jawbone. And I think most dentists would probably try to do what's called a block, meaning they have a much bigger area of anesthesia, and then followed by infiltration, meaning they literally put local anesthesia right around the area that they have to work just to be 100% sure. And I think our patients can probably tell us better how often the injections are successful or not. But I think no one can say that fibrous dysplasia itself is somehow doing is causing the difficulty in getting the block. It's probably more an anatomical issue.
Well, I think the best evidence for that is that patients with fibrous dysplasia do not have routine neurosensory deficits, meaning numbness in their jaws just because of growth of the fibrous dysplasia bone. So for that very reason, it would seem to me that the nerves should be intact, they should be functioning normally, and perhaps like Dr. Lee saying, it's just an anatomical consideration.
In a patient diagnosed at age 3 by a limited skeletal study with no identifiable CFD, is it possible for CFD to appear later in childhood puberty?
It's a plain film, you said? Oh, skeletal study, a limited skeletal study. So I'm assuming it's an X-ray. So if it's an X-ray, as we had mentioned earlier, the best way to determine where the lesions are in the skull base really would be a CT. And so an X-ray it'd be hard to say whether there's a lesion there or not.
It's possible.
Sure. But you missed it, most likely.
I think it's possible that you could have missed it, especially in the craniofacial skeleton. You have to remember that even if we're getting a CT scan, the structures are very close together, and in a pediatric patient, things are very tiny. So it is potential to miss something. That study that was done was looking at, all comers. And I think that, it's important during the pediatric years, especially if other bone lesions are found, to continue to do studies to just make sure nothing is being missed.
How can we encourage docs outside of the United States to be updated on treatment and research? The UK is behind.
About that, actually. Well, I think it's organizations like this one that promotes current literature, and it's educated patients like you who go back and say, hey, did you read this article? Or, hey, did you see what they put out on the internet? I mean, there's so much out there. It's really a matter of helping patient advocates and patients themselves make sure their physicians are on the mark. For clinicians, it's up to us to publish more and get our information out there so that we can provide as much knowledge as we know, but as you're all finding, there's still a lot of work for us to do as well.
Generally, I like my appearance, but FD is pushing my eye out of place. It's protruding out of the socket. Do I need to have surgery to fix this? And if so, when should I have such surgery?
Actually, I think you'd be better.
Yeah,
I mean,
that's
contouring, right? But
yeah, the contouring of the periorbital bones is something that would be done for something like this. And, as we had been saying, it'd be best to wait until there's skeletal maturity so that the likelihood of rapid regrowth or continued growth doesn't become an issue. It's really up to the person. I think it's an individual choice. Some people really want that area contoured for both cosmetic and functional purposes, and others feel that it's not as obvious. So that's a personal choice. But contouring in that particular region does require a pretty big surgery, and it requires an incision that goes across the scalp and pulling the soft tissue down to expose the bone. So it's extensive. But I don't underestimate the importance to that individual to have this done. And this is something that has to be discussed with the craniofacial surgeon in terms of how much of a psychosocial burden is this for this person.
I think this is probably going to be answered by Wendy. I'm going to have my first craniofacial surgery in 6 weeks. I want to be prepared. How much pain should I expect after surgery? What's the best way to handle it?
So I guess we're all different, and our pain tolerance levels are all very different. I've had 3 optic nerve decompressions with the craniotomy, and I don't remember the first couple days right after surgery. I know I took it very slow, and I've been on pain meds. Probably, I guess, dealing with the headaches. I had headaches from surgery, but I don't really remember the overall pain in my skull being that bad. And I don't like pain meds, so I tried to get off them as soon as I could anyway.
Do any of the surgeons want to speak to this?
I have no feeling.
Yeah, I don't think that the patients with FD, though, have a higher pain need. The surgeries themselves can be painful, and having performed a number of these jaw reconstructive procedures, a lot of patients will be off high narcotics within a week or two, and that's with or without fibrous dysplasia. And a number of patients will feel that their pain is well controlled with Motrin and Tylenol, just the two together. But I don't think we've had there doesn't appear to be a higher issue with pain after surgery among the FD group.
Is there a procedure to replace the gums? I think this probably refers to osteonecrosis of the jaw.
There is it.
There is gum grafting that can be done, either auto grafting, meaning from the person. Sometimes you can take some tissue from the palate of your mouth and put that over the teeth and use that as a gum graft. Other grafts include, cadaver material or other such material, which are called allografts. I'm not exactly sure if it is referring to osteonecrosis. We do not graft over osteonecrosis because it's dead bone.
Right.
Yeah.
So I have a large hole
It's keeping it
in
alive is the problem.
my jawbone
I mean, you can do it. But
from the necrosis, and I've asked my oral surgeon many times, can we get to a point where that hole can be
Closed.
grafted or covered? He's told me he felt that we may have to debride that area every few years, but because I had a large amount of bisphosphonates for a lot of years, so I may be dealing with this a while, and I may have a hole. Right now, I feel I'll have a hole the rest of my life.
Well, and I think that's important too, because in osteonecrosis, oftentimes less is more.
Yeah.
And so we can actually, by doing a surgery, make the situation worse. So that's a very valid point to consider.
And just something to think about with ONJ, it can be a stable condition for a very long time. And as Wendy's pointing out, it's really a matter of maintaining it and trying to avoid infection. So it's not always to get rid of it and then plug it up. It's really just to prevent infection, keeping the area clean, and there may be an area that has bone exposed, but so long as it's not infected, it can stay that way for a long, long time without causing too much discomfort.
Okay, this is another practical question. How long will it take for swelling to go down after surgery so I can see my new face?
Well, I think we can say it depends on what the surgery is. And in most cases, the swelling, the most immediate postoperative swelling will go down within 2 weeks. But sometimes facial swelling in particular can last up to 6 months. I tell patients within a month, most people are out and about, and they'll feel comfortable going to the grocery store and going shopping, but all the swelling will typically take 6 months, and that's with and without fibrous dysplasia. It can take a while, but be patient.
Okay,
wanna
final
add
question, I
anything
think.
to that, Wendy?
What is the most important thing you, as physicians, have learned about fibrous dysplasia from working on it as a clinician?
Listen to the patient and let them teach you.
I agree. What she said.
Well, I feel like I've learned a lot. I think one thing is, in that vein, to listen to what the complaint is, because what I might be seeing is something that's totally different than what the person actually wants me to fix or wants me to address. I think another thing that I've found very striking, and I've been very fortunate to come to, several of these patient family advocacy forums, is that it seems that, getting older with fibrous dysplasia, many people are still complaining of having swellings or having symptoms, and I think, while we know a lot about younger people and what they're experiencing, I think it's important to also, as we're getting older and our patient population is getting older, to, begin addressing some of those things.
Okay. Go ahead.
Share, Wendy.
You have the most info.
So I guess what I've learned over time is I need a team of doctors that will let me be part of the team. And I've fired a few doctors, if you put it that way. And I have no qualms about doing so if they're not going to allow me to be part of the team and understand that there's a possibility I know more than they do about it.
I think that's really important. I mean, you have to have trust in your doctor. And if they're not listening to you, you really should look for somebody else. Everybody that I respect as a doctor, if somebody says they want a second opinion, I try and find them somebody to get a second opinion, because we don't know everything. And, it's always nice to have somebody else's eyes on it to figure out, no pun intended, that, just to make sure that, you're not missing something, or, there is maybe possibly somebody else that can help, or have seen something that did help. So, you have to have trust in your doctor, but you also have to make sure that you're your own advocate. Is what I'm saying.
Are there any other questions from the audience?
I just have one question. Our daughter is now 14, and she hasn't been able to smell.
Anosmia.
I guess from the age of 5.
That's pretty common.
And I'm just worried that she's going to
Don't bring it up.
into adulthood and just practical stuff like not being able to smell. The smell.
Does it bother her?
The other day she was baking, she didn't even know that it was burning. And we smelled it and she didn't, and I'm just worried how extensive it is for her to go through the surgery and when it's advisable.
You can't do anything. No, there's nothing you can do.
Can smell be fixed?
No.
Wow. Can smell be fixed? Unfortunately, there's so many, the nerve endings and where the nerves are is at the base of the skull. It's a really, really tricky problem. And unfortunately, there's no reversible treatment.
Interesting we didn't mention it. Though.
But I think what may be very important is to have a couple of smell tests. There's the very infrequently used smell tests, and this condition is called anosmia. But to try to reverse it would be exceedingly
It's unlikely
difficult.
to happen. It's not going to work. But it can also be caused by medications and lots of things. Steroids.
Sure.
This is a question about whether FD can cause glaucoma. I was recently diagnosed, but wasn't sure if it could be from FD or a medicine I had taken.
No, this is the short answer.
The short
Not
answer?
related.
No?
Not related.
Not related.
Just a question about having the craniofacial, debulking and that, like now being in my 50s, still having pain in that. You're saying that the likelihood of it growing back would be less than had I chosen to do it in the 20s?
To do a debulking now?
Yes, or reconstructing.
So I would have to.
Can you restate the question?
So, will you have less likelihood of regrowth now that you're
Age 50.
older?
And pain after.
Pain and regrowth are probably two very separate things.
Okay.
So debulking may or may not do anything for the pain. At this age, it may be reasonable to say, I want to now address the asymmetry in the face, and chances of regrowth is much lower now. But bear in mind the regrowth, and treating the regrowth may do absolutely nothing for the pain.
But I think it's also really important to separate out the pain. That surgery may not fix pain, and it might make pain worse. And we really don't have enough information to say one way or another.
Even at this age.
We just don't have enough data. So, that's why I was saying before, I think it's so important to have this risk-benefit discussion with your physician so that you can all be on the same page and understand, well, if this does happen, what are we going to do about it,
Right.
and think about all of the different concepts. So that way you can make a really informed decision about whether or not you want to have it done.
Okay, we have two more questions. I'm going to read this one, and then we've got one back there. Okay, if we have time, we'll get to the one over here. Dr. Burke and Dr. Lee mentioned that most symptoms will show up by age 15, but it sounds like a lot of develop later and gradually through the life for Wendy. How typical is it for complications to develop later in life?
I think the difference between complications arising from various symptoms and sequelae of the disease and the actual lesions themselves based on their anatomy are two separate things. So I think what we're saying is that based on some studies that have been done, we've seen that most lesions we can see on a bone scan, for instance, by the age of 10. that's sort of what we're getting at. As far as complications and other sequelae that you might have from either the bones or other such things affecting the bones, neurosensory changes, that I think, this is an aging population, and it's very hard to tease out, like, well, what would happen if you didn't have fibrous dysplasia and now you have fibrous dysplasia, and what is being affected because of that. So I don't think we really know the answer, but I think more research needs to be done into it.
You mentioned that a CT scan is the gold standard for craniofacial. Our son always has, his doctor has an MRI each year. Is that better for seeing the optic nerve, or should we also be having a CT scan annually?
Yeah, that's a really good question.
Yeah, so it's one is concentrating on the bone, one is concentrating on the brain, and in this case, the optic nerve. So truthfully, I think all the functional tests are much more important than the MRI. I think that doing the MRI isn't going to tell you much. It's essentially, you're not going to act on it unless there's functional tests, so why do it in the first place? If you were thinking of doing something with a skull, then sure, get a CT over an MRI because you really need it. That's what that's for. But I don't think that the yearly MRI tells you anything useful. What you really want to do is have a good functional test. So what I'm talking about is, side vision, color vision, contrast, all the things that we use to try and figure out is the optic nerve working correctly. If it is, I don't think you need to do anything more.
I think the piece of good news, though, is that the MRI is not adding any radiation.
It doesn't cause any problems, but it just causes.
But it's probably just the physician or the doctor's way of staying on top of monitoring your child. But as Dr. Fitzgibbons is pointing out, really following the functional tests and the baseline tests would be more critical in terms of would you act on something.
Okay, I wanted to acknowledge that some other questions have come in that relate to endocrine issues, and I'm saving them for the endocrine panel. I want to thank our presenters and question answers, and we will close the session.